This was a cost effectiveness study that we conducted with colleagues at the Uganda Cancer Institute in Kampala and colleagues from Fred Hutchinson Cancer Research Center in Seattle. They had developed a very robust and detailed Burkitt lymphoma treatment program in Uganda to treat one of the most common prevalent childhood cancers in the region. And we undertook to do a costing study to demonstrate the degree to which that treatment program is cost effective or not, to help inform decision making at the policy level nationally around whether to prioritize treatment of this cancer, to provide financing for it, and whether it's sustainable in the context of their health system. So we used internationally accepted thresholds for cost effectiveness published by the WHO. It's called the WHO Choice Methodology. And these take into account relative GDP in a country as compared to others to assess what is cost effective. So something that has a 3-to-1 ratio of the cost per disability life year averted to per capita GDP is considered cost effective, and that with a 1-to-1 ratio is considered very cost effective. Now, I should stress that these don't speak specifically to affordability in a given health system context, but they give some measure of being able to adjudicate relative cost effectiveness as compared to other interventions internationally. So we found, perhaps unsurprisingly for those in the pediatric cancer world, but surprisingly for those outside of it, that it was a very cost-effective intervention. So the cost per DALY averted for the full treatment program was $88. And that's largely because these children can be cured of their disease and live long, healthy, fruitful lives as a result, which is in sharp contradistinction to many adult cancers. So from that point of view, it's arguably a very wise and effective health system intervention and should be prioritized as a result, but again, needs to be considered in the context of competing priorities. I should say this is, to our knowledge, the first study that actually took a micro-costing approach to doing cost-effectiveness analysis. And what that means is we prospectively tracked patient outcomes and had detailed data at the patient level on both outcomes of treatment and the costs associated with that treatment. So very little modeling went into the analysis. It was actually prospective clinical data.